here at the MST booth in LA, 2025 ASCRS. So for me, my passion for addressing vitreous opacities now, which is a new term, instead of floaters, clinically significant vitreous opacity, CSVO. Because the idea now is that floaters are not just a natural aging process, it's a condition that really affects daily functioning for patients. About 7 in 10 people are going to have a floater, and about 30% of those patients, it's going to be clinically significant long term. It's not the surface only, it can be the vitreous. Vitreolysis is a great option. I do a lot of laser treatments. So for a Weiss ring, kind of a patient where, let's say it's a small opacity, we can actually isolate it, get a good understanding of where we are in the vitreous. Once we know the floater's in focus and the retina's out of focus, we can fire these YAG lasers, and what you see is it does break up. Here's the thing, a lot of my patients don't come in with those small pieces. A lot of my patients come in with this stuff. Up to 40 to 70% of our patients will have increase in vitreous debris after cataract surgery. So imagine, biggest part of our optical system is the vitreous. So we talk about the surface of the eye, we talk about the lens. Well, if your vitreous looks like that, how can it not impact the quality of vision, the contrast sensitivity? Historically, vitrectomy is something that was not in our hands as anterior segment surgeons. We always were afraid. Jerry Sabag showed in a lot of his data many years ago that if you do a partial vitrectomy, a core vitrectomy where you're not taking the entire vitreous base, you're leaving the vitreous attached to the retina alone, not only do we see safety, he found no tears or defects of the retina. And so we take that concept and can we do that in a more effective or efficient way, and one that's more palatable for a lot of anterior segment surgeons like me. And that's what the One Step has done for my practice. And I can truly say that the One Step has for multiple reasons, and we'll talk about it in a second. But what it entails is basically a needle vitrector. It's a 27 gauge needle. So the needle tip allows you to enter, allows fluid to go irrigation, right, or aspiration rather. And then you have this tip here, which is a dual blade vitrector. It's going back and forth. It attaches to any phaco machine. There's an AC maintainer that's also in this kit as well, because you want to make sure you have a good stable chamber. So there's no trocars, but we keep the eye stable with an AC maintainer. So you push the AC maintainer, make a 1.0 keratome incision into the eye. It fits beautifully into the eye. We measure about 3.5 millimeters behind the limbus, and we enter anywhere it's convenient for you, and I enter with conviction. There's a little bit of resistance through the sclera. I do have these stay sutures here. If you don't have those stay sutures that keep the eye still, using a 0.12 to stabilize the eye or some counter traction is important. But I enter and I stay in the anterior vitreous behind the lens. Now here is probably a couple of the most important points. We have irrigation here to about 40 to 60, depending on the eye. So we're keeping irrigation here, but the vacuum, the key is not to go way down the foot pedal and crank up the vacuum. We are below 100. I'm usually at the 60 to 70 range for most of my vacuums. You want low vacuum so you're not tugging at the peripheral vitreous. Very low vacuum so only those opacities, only the vitreous that's liquefied is going to come to the tip. We stay there and don't move around. And you can see things come all the way to the tip. I may go down more a little bit. I may turn it side to side. That's the tip there. So I'll do that slowly. Turn it side to side, may go down a little bit more. Remember, 15 millimeters, so you cannot go down and hit the posterior pole with this thing, no matter how far you go in. So you can go all the way in, but the idea is in very slow movements and low vacuum. That's how we maintain high safety, by not pulling the vitreous away from the retina to induce those tears and breaks in the periphery. So once you feel comfortable, I just came out of the eye, I take out the AC maintainer and fill up the AC, and that's it. And this is done, truly done in the office, topically, with 5 milligrams of Valium. Patients are really comfortable. Now, the beautiful thing about this is there's very little inflammation. These patients the next day are quiet. Yes, you may put them on an NSAID or maybe BID of some steroids for a week. This is the exact same picture intraoperatively, right before I did the surgery and right after. And look at the difference in the quality. It looks like a whole, like I polished the capsule or polished the lens. That's just by removing vitreous. Now, I've done about 170 now, I think, of these cases. But we looked at 40 eyes of 40 subjects. We had 3-month follow-up, and we did not use trocars, the same technique for every patient there. And most of the subjects were having years of complaints of opacities. A few subjects had it only for about 6 months, but definitely significant as well. And what you can see here, look at the HOA. The HOA of the cornea here, or the cornea did not change. The internal HOA improved. More importantly, look at the MTF curves. What's normal is that at about 10 cycles per degree, you want to be about 60%. That's normal. This is beforehand. Look at how low that contrast is. Here's after. And so we had about 61% of patients who had a DLI of 7 or above before surgery. And then after surgery, about 80%. So almost 20% of patients we improved to DLI. And the average improvement in higher order aberrations was about 0.26. We also had floater questionnaires. About 70% had 0 symptoms at all, like completely gone. about 15% of patients here had some that, once in a while, and about 10% still had some that were still bothering them. So it's not a cure for every patient, but a significant difference. 90+% of patients, for the most part, are like, wow, this is incredible. After surgery, no one had severe symptoms. So this is a game changer from a quality of vision, quality of life perspective. We kind of graded the amount of floaters that were kind of impacting their central visual axis. And at the baseline, you see here, majority of patients, it was pretty much half or greater of the entire visual axis that we could see in the pupillary margin. And at day 30, very few patients still had a couple that we could see in the periphery of the visual axis. So every one of our patients got back to baseline vision or improved by 1 week. That was really fascinating because you think a vitrectomy, that's a long recovery period. And here we found now about a 1.5 line improvement with near with these multifocal patients. Again, when you take that vitreous or debris out of the way, that contrast improves. A lot of times that reading improves as well for these patients as well. So here's the thing though, safety. ACs all were quiet by 1 week, which I think is important. Very rare to have any inflammation. In that first 5 patients, I had 1 patient with a tear. Now luckily, we found a tear in the periphery, got it treated, patient still 20/20, had no sequelae after that. But it taught us a lesson. Let's decrease the vacuum, keep it still to protect from pulling at the vitreous base. Since that patient, we have not had a patient who has a retinal tear or detachment since then. This is a great tool, a great technology if you have a broken capsule. With the right technique, this technology, I think any anterior segment surgeon has the opportunity to take care of these patients.